So we are going to begin our next panel, which is exploring community solutions in a few minutes. But quickly, we'd like to share a few videos with you from our Find Your Words campaign. And it was referenced earlier in Dr. Mordecai's comments this morning. So could we please play the videos? Thank you. Great. So it's my pleasure now to introduce Colleen Carr. She is the director for the Secretariat for the National Action Alliance for Suicide Prevention, or the Action Alliance, the nation's public-private partnership for suicide prevention. It coordinates a comprehensive national suicide prevention response in the U.S. and works with more than 250 partner organizations to coordinate the implementation of the national strategy for suicide prevention. She's responsible for providing strategic direction to the Action Alliance's distinguished leadership and working with leaders from federal agencies and the private sector to help coordinate and align efforts around advancing the national strategy for suicide prevention. She cultivates partnerships and commitments to support the our national efforts as well. Welcome, Colleen. Colleen will then be introducing the other panelists. Thank you.
Come up at the same time. Okay. Good morning. How is everyone? So I just want to thank Kaiser for having this event today, and Dr. Mordecai, who's been on the Action Alliance Executive Committee for a number of years now, for their national leadership around suicide prevention. It's really great to see where this work continues to go. We have a panel today that's going to be all about exploring community solutions. So a nice follow-on to our morning topic around clinical, and we'll talk a little bit about how these efforts really need to come together into a comprehensive approach. Oops. So a little about the Action Alliance. Dr. Franklin referenced earlier today and is another one of our executive committee members in the room today. The Action Alliance started in 2010, and we are the nation's public-private partnership for suicide prevention. And we're really tasked with coordinating the national response to suicide, advancing the national strategy, and bringing new non-traditional partners to the table. Because we know if we could solve the suicide problem with mental health and healthcare alone, we'd be making a lot more progress than we've made to date. And so we're really charged with reaching out to new partners and new sectors and getting them involved in our effort. Around the table, we have all of the federal agencies involved in suicide prevention, so senior leaders from defense and VA and education, justice, homeland security, and the many components of health and human services from CDC to SAMHSA to HRSA and NIMH. So a really broad diversity around our public sector stakeholders. And then on the private side, we have leaders from the auto industry, construction, railroad, news media, entertainment, law enforcement, technology, social media, etc. So feel free to go to our website to see the breadth of some of our partners involved. But really, we're all aligned around advancing the national strategy, and that's our roadmap. And I'm going to talk a little bit about our priorities and lead us into the community conversation. So we have the national strategy. One of the first things we did at the Action Alliance after being launched in 2010 was revise this. And in 2010, with the Surgeon General's office, released the updated strategy. There's 13 goals and 60 objectives. So one of the first things we realized was that we were not going to do all of that at once. So we've selected some high priority objectives from the national strategy, which I'll talk about today. Our first priority is transforming health systems, and this is where the early efforts to catalyze zero suicide came from around 2012. And so this work includes both scaling up zero suicide as well as transforming crisis care through the Crisis Now initiative, improving financing, and care transitions, which Dr. Cornett talked about as well. But we know that healthcare is just one piece of the puzzle, because we need to have strong communities around health systems to make sure we're getting people into care. But then when they're leaving care, they're going back into the community. The community is going to be where they're living, where they're working, where they're going to worship services. And we really need a comprehensive approach. And so we have transforming communities as our second priority. And this is where our work with faith communities comes into play. And I'll talk a little bit about that, but Dr. Molock will certainly go into more detail about the role of faith communities and the role of the workplace. We know people, especially adults at highest risk for suicide, spend the majority of their day at the workplace. So we need workplaces to be prepared and supportive of those who are struggling with mental illness, thoughts of suicide. And it's also where people go back after treatment to find meaningful work, as Dr. Franklin talked about this morning. So we need to improve our health systems, we need stronger, more supportive communities, but we also have a national narrative about suicide prevention, and we're committed to really changing that conversation about suicide nationally so it's supporting our prevention efforts. For far too long, we didn't talk about suicide at all. Then we started talking about it, but our narratives really focused on the death and the despair and the tragedy of suicide, but we know there's so much more there. We know that millions of people think about suicide every year. And the vast majority of them do not go on to die by suicide, as we've heard. So what is their story? What is their story of hope and recovery and survival in these circumstances? And how can we tell those narratives? And so that's our effort nationally to change the conversation. Our partners at CDC released this data over the summer, and it was so important because we know that it's more than just mental health, but we needed stronger data to point us to the direction of where do our public health efforts for suicide prevention focus. So we know now that while 54% of suicides had a known mental health condition, all of these other factors were playing a significant role in suicide. So relationship problems, substance use, job, financial problems, legal problems, physical health, or a crisis that has just occurred or is about to occur. And so this, again, directs us to that public health approach where we can address these factors as well as the mental health condition. So our community effort, as I mentioned, is really focused on both faith and workplace as where we've started. We have a faith task force that has launched the Faith, Hope, Life campaign. And this is really focused on getting every faith tradition involved in suicide prevention nationally. We have a website where there's resources for various faith traditions outlined by the traditions, both Abrahamic faiths and non-Abrahamic faiths. And we really wanted to make this a place where people could go to get started. We know faith leaders are already involved in suicide prevention because people are going to them in crisis. They're conducting services when someone who has lost their life to suicide and supporting families. But we wanted to be more intentional about that. So one of the first things that we did was create kind of an easy entry point. So we want faith leaders to help us get people into treatment. We want them to help support families, but we really want them to start the conversation. And so we launched about 2 years ago the National Weekend of Prayer for Faith, Hope, and Life. And the idea was really to just start with, can we say a simple prayer in whatever faith tradition it is, just as we pray for those who have physical illnesses, can we start to include those who are struggling with mental illness and thoughts of suicide? And this has really, I think, taken off like wildfire. We were not expecting the readiness and the hunger among faith communities to have a space where they can have this conversation. And I'm just going to play a short video.
September 10th is World Suicide Prevention Day.
This weekend, the National Action Alliance for Suicide Prevention invites faith communities across the nation to pray for those
whose lives have been touched by suicide.
Pray that we can all grow in faith
that brings hope and hope that brings life.
Whether in your church,
your temple,
synagogue,
your mosque, or even by yourself, join us.
Join us. Join us.
As we pray, let us pledge to be aware of those around us
who are struggling with any of life's challenges,
especially those affected in any way by suicide,
and to be there for them in their times of need.
Be there in person.
Be there with care.
And be there with prayer.
On this Faith, Hope, Life Day,
We pray for emotional,
mental, and spiritual healing.
Just as we regularly pray for persons with physical concerns such as cancer or heart disease,
We especially pray this day for those dealing with mental health concerns.
And feelings of hopelessness.
And for the people who love and care for them.
It's time to break the silence around suicide.
And help all who struggle.
Please join us.
join us.
Please join us.
كن معنا بالخير.
te invitamos, únete a nosotros. Hilacom, Mungsarayosese.
Xin đến dự ngày cầu nguyện với chúng tôi.
Because where there is faith, there is hope.
And where there's hope, there's life.
So Faith, Hope, Life Day.
Let's be there.
In person,
With care.
With prayer.
Great. And we'll hear more in a minute about the role of faith communities. But from a suicide prevention perspective, it's really been amazing to see what kind of traction this has received in such a short period of time. And I think what we find is when we go out into the community, there's a need and there's a hunger for this information. And how can we forge those partnerships? We did a public opinion poll last summer, and what we found was that the vast majority of Americans know suicide's an issue. You know, it's on the nightly news. We're hearing about it more and more. But what we haven't done as good of a job of doing is saying, and here's what you can do about it. We say it's complex. We say, you know, all these factors, but we haven't empowered everyone to kind of play their role. And we found 4 out of 5 people in the public opinion poll said, I want to know what I can do in simple steps. And this is part of that conversation. The Be There campaign from the VA and DOD is part of that conversation. So how do we layer all of these? The health system, zero suicide, the faith communities, the workplace, and this national narrative. On the national narrative side, we have 3 key audiences. We work with the news media, the entertainment media, and everyone who's messaging about suicide, which is everyone in this room today and more. And I just want to point to 3 key resources. We have the media guidelines that we've heard about already. This is when we're talking to the media, our messaging matters, but we can also help them follow their journalistic ethos in a way that is reporting on suicide in a way that's safe and accurate and actually helps tell better news stories. We have a public messenger resource at suicidepreventionmessaging.org to make sure when we're putting messages out there, they're strategic and action-oriented and moving beyond awareness and moving to action. And then just this month, we released entertainment depiction guidelines, which was an effort over the last 12 months with the entertainment industry and suicide prevention field in collaboration with SAMHSA and the Entertainment Industries Council to really develop a tool for content creators because they're creating this content. We're finding out from the research that it's impacting suicidal behavior, and so we've gone and developed suicideinscripts.org as well. So I'm going to stop there, and we're going to hear from our panel today. And first up, we have Holly Wilcox. Please come on up. Dr. Wilcox is an associate professor in the Johns Hopkins Bloomberg School of Public Health and School of Medicine. She's involved in several suicide prevention initiatives in Maryland and nationally, and co-leads a federally funded project focused on conducting data linkage and informatic approaches to utilizing data resources to improve risk identification and prevention. Thanks for being here.
Good morning, everyone. Thank you so much for inviting me to be part of this day. It's been really great for me so far to hear about a really strong synopsis of the work that's going on and thinking about ways to go forward from here. So my role today is to talk about schools. I'm going to go upstream, pretty far upstream also. I'm going to talk about 2 evidence-based approaches and one promising approach that's being rigorously evaluated right now. And what I'm going to ask you to think about is maybe taking these approaches, one in primary school, one in middle school, and one in high school, and thinking about layering them and making them part of every school's programming. We have a real opportunity with health education class to be able to implement and embed suicide prevention related programs or programs that can impact suicide, have been shown to impact suicidal ideation. We have an opportunity to embed them in a naturalistic setting such as schools. I've been in the field of suicide prevention for about 30 years, and the challenges that we face, of course, we talked about stigma earlier. We've talked about access to high quality mental health care in the community, which is another issue. But I do think that schools are a natural place to reach students, and most kids attend school, so it makes a lot of practical sense to think about how we can move upstream and embed high-quality programming into schools. The other problem that we have in this field of suicide prevention is that most of what's available in terms of prevention programming is for people who are already in crisis. Some of what I'm going to talk about today focuses on preventing that crisis from ever happening and the disruption in terms of social, academic fields, friends, and family that those problems can cause if issues aren't addressed early. So in terms of school-based programs, right now there's a current evidence base showing that programs that are implemented in primary school that target aggressive, disruptive behavior can, a decade or more down the line, reduce risk for suicidal ideation or attempts. There are 3 examples of this. I put 2 on the slide. The Seattle Social Development Program, which I'm not going to talk about today. The Family Checkup is another program that's been implemented that has shown to have an impact downstream on suicidal thoughts and behaviors. But today I'll focus on the Good Behavior Game, which is the program of the 3 that I've worked most closely with. So what is the Good Behavior Game? It is a universal intervention program, much like Dr. Franklin was talking about the different levels of intervention. Good Behavior Game is universal, so it's implemented to everyone. And in this case, it was carried out and studied by our group at Johns Hopkins as implemented in first and second grade students. But we have a project now going on in Blackfeet Nation in Montana that's looking at studying the Good Behavior Game's impact in nursery school. In this case, the Good Behavior Game is directed and targeted directly at disruptive aggressive behaviors manifested in a classroom setting. And back in 1985 and 86, when this the trials on Good Behavior Game first started, it had been replicated around 20 times, and it was of interest to the school system. We have had 3 generations of Good Behavior Game trials in Baltimore, Maryland, and I'm going to talk a little bit about those trials and the results. So in terms of what is the Good Behavior Game, it's pretty straightforward. It's a program that teaches teachers on how to manage their classroom. Typically in schools, kids in first and second grade, they don't change classrooms. They're with the same teacher all day. And the teachers can be given tools to impact behavior. In this case, students sit in groups, and the teacher defines the rules for the students, and they understand them, even if they can't read. The rules are posted, and the kids work in teams when they're playing the game at different periods during the day. They are told that they're playing the game, and there will be tick marks put on the board if the student violates any of the rules of the class in any of the groups. So there's a chance for all the teams to win the game, and there's the chance that once they do win the game, they're distributed rewards. And so rewards can be whatever's rewarding to the students, and it's really important to think about selecting rewards that are affordable and maximally rewarding. So in Baltimore, there are dance parties, there's pencil tapping, teachers can get really creative with delivering rewards and what the rewards are. And the results of this first generation trial were published in Drug and Alcohol Dependence in 2008 with all the impact on a variety of outcomes that I'll go over here. This is just looking at the outcomes across different domains. So you'll see there was an impact of this GBG as played in first and second grade with high fidelity in this instance. So the teachers did this and were monitored and mentored on how to implement this program. You can see kind of across the board around a 50% reduction or a 50% lower incidence in the GBG group as compared to the standard setting, which was the control condition that didn't receive the intervention. My results are on the bottom from my paper, which focused on suicidal ideation and attempt. And you'll notice here that for the other outcomes, there was more impact in males and highly aggressive males. And in my paper, there was slightly more impact in females, actually. So after this special issue came out and a couple of other papers were published on high school benefits in terms of high school graduation and sexual risk behaviors, an analysis was done by the Washington State Institute for Public Policy, and they found that for every dollar invested in the good behavior game, there was about a $64 return in investment in terms of the benefits across the board and the outcomes. Now, this first generation was done with fairly high fidelity, and it hasn't been replicated to the same extent by our group or others in terms of the suicide outcomes, but we're actively trying to replicate those initial findings. In terms of another approach that's gotten a lot of attention, is the Youth Aware of Mental Health program that comes from Europe. This is a program that was evaluated in a very large randomized trial that involved 10 countries in Europe, mostly high-income countries. Over 10,000 students were part of this. And what they did is they compared a lot of the interventions that we use in the U.S. in schools, like gatekeeper training, question, persuade, and refer, this new intervention called Youth Aware of Mental Health, which is pretty much a role-playing type of intervention approach, and screening and referrals, kind of like Signs of Suicide Teen Screen program, which you may be familiar with, and compared to control as well. And what they found is no real difference at 3 months for suicidal ideation or attempt, but they found a pretty dramatic reduction of around the magnitude that we found in the good behavior games, so about a 50% reduction in suicidal or reduced incidence of suicide ideation and attempt among the Youth Aware of Mental Health program group. And this program is about 5 hours, and it's heavily based on role play, where the kids select problems that they often encounter, and they problem solve together in groups. And it's an interesting approach because it's very practical, and it's kid-driven because they pick the problems. And it's discussion-based as well, and they get education. The other program that we have going right now is funded by the Born This Way Foundation, which is Lady Gaga's foundation. We've taken teen mental health first aid from Australia and have brought it to the United States. They have a randomized trial of teen mental health first aid ongoing right now in Australia with some promising results. They're doing the 18-month follow-up. Actually, really promising results, but I can't tell you about it because it's not my own work. But anyway, teen mental health first aid is directed at the youth. So the youth get trained, kind of like gatekeepers, they're trained, and it's about a 4-hour, it's easily embedded into health education class and into the curriculum of the school. And it's a peer-to-peer program, so the idea is how to recognize your friend when they're in crisis and what to do with your friend when they're in crisis. It's very practical, high-quality materials, interactive, and 10% of the adults in the schools are intended to be trained as well. These are the states that are participating in our Born This Way Foundation, piloting and adaptation to the U.S. cultural context. This is being done in high schools. And hopefully in the future, we'll develop the program for middle schools as well. So this is our trajectory now. Right now, we're piloting. There's going to be a launch that will take place in the fall, and the program should be readily available sometime in 2020, hopefully. So what is needed to address in the school domain? Well, one big concern is that these programs, even though they're evidence-based, are not making it out into most schools. So most schools are not implementing them. And if they are implemented, oftentimes they're not sustained. So we have to think about potentially some public policy solutions to get these programs embedded into schools and how they can be implemented and sustained long term. And most of these programs show that unless they're implemented with high quality or high fidelity, you're not going to get the payoffs or the returns that we would expect, like from the first generation good behavior game trial. So that's another thing we have to think really carefully about. And I'll stop there. Thank you.
Next up, we have Dr. Sherry Molock. She's an associate professor in the Department of Psychology at George Washington University. And she teaches undergrad and graduate courses on developing suicide and HIV programs for teens in African American churches. She serves on the steering committee for the Suicide Prevention Resource Center and the National Action Alliance for Suicide Prevention's Faith Task Force, and as a grant reviewer for NIH, and is a founding pastor of the Beloved Community Church in Maryland.
Thank you also for inviting me. And excuse my voice, I'm a little bit hoarse because there's a lot of pollen out today. So I wanted to acknowledge Talitha Arnold, who I'm actually substituting for her. She's the co-chair of the Faith Task Force of the National Action Alliance. I'm also a member of that task force. And so I just wanted to make sure that we acknowledged her contribution. I do wear two hats. I'm going to be bringing both of those hats today as a professor in psychology at George Washington University, and also my role as a co-pastor of the Beloved Community Church. I've been at GW for 20 years. I've been a pastor for 11 years. I've been in ministry for 20 years. Okay, so why should we include faith communities as part of our first responders and part of the people who should be associated with helping people get good mental health care? The bottom line is that in faith communities, a lot of times for people who are participants or members of a faith community, it's like one-stop shopping. And I'm going to talk more about my experience, my context, which is the African American Christian church. But mental health issues affect all kinds of people and from all faith traditions. Faith leaders are definitely often first responders, even if they don't feel qualified or trained to address some of the mental health issues. Oftentimes their community members will feel more comfortable talking with them as opposed to a mental health professional. In fact, the reason I got involved with this research was because I realized that most people would not see me as a mental health professional, but would talk to me because I was a member of a faith community. Faith communities are very holistic in their approach to the family and to the person's issues and concerns. We interact with people in diverse settings. Congregations include people from diverse workplaces, including mental health professionals. And so I was privileged to be part of the founding of a pastoral counseling center in Prince George's County. It's called the Baraka Counseling Center, Pastoral Counseling Center, which still exists. And we started this about 25 years ago. And it grew out of the African American Episcopal Church, just having a huge need for people who wanted to get some mental health or emotional issues addressed. And the first month that we opened, which was in, I believe, 1996, we saw 600 people. All of the providers there were members of that church community. This was a mega church. All of us had mental health backgrounds. We had a psychiatrist, social workers, myself as a clinician. I actually had students of mine training as externships in that setting. So there's a lot that you can do there. And then also we know that oftentimes the mental health crisis also becomes a crisis of faith. So there are barriers to seeking care in faith communities. One is that for many communities, suicide violates faith communities' cultural gender role norms. So, for example, I know in my own community, oftentimes there's a perception that men don't think about suicide, and if they do, they're weak. Sometimes suicide can be seen as a moral failing or as a crisis of faith, that if your faith was strong enough, you wouldn't be thinking about suicide. And it also, I know in my own faith tradition, a lot of times black people think that suicide is a quote-unquote white thing, and that that's not something that occurs in the black community. On Tuesday, I was at a congressional hearing from the Congressional Black Caucus about this very issue. So some of this has a lot to do with we need to educate people that that is in fact not true. And we know that there are slave narratives of people jumping off of ships, and so that people have always completed suicide in all communities. And also there's sometimes a big stigma associated with mental illness in particular. There's also distrust of mental health professionals. When I was in seminary, people would blatantly say things like, don't talk about your Jesus or your faith in a mental health context because people will try to take Jesus from you. There's a whole concern about that mental health professionals will minimize your faith beliefs or traditions. And there also, and this is true, that many mental health professionals are not trained to deal with faith concerns in the context of a session. And we'll talk a little bit later on about how you can do that. Clergy know very little about suicide lethality. So I have had situations where people have been acutely and actively suicidal and people have prayed and not referred. And so prayer is really important, but this prayer plus referral is important as well. Clergy are less likely to make mental health referrals, particularly if the clergy engage in what's called other world theology. Other world theologies are ministries that focus more on the afterlife and maybe promoting the things in this life or this context are difficult and you should expect trials and tribulations, but the focus is going to be on living a pious life so that you can have an afterlife. Other churches focus more on what's called this worldly theology, and those churches tend to be more concerned around social issues and social justice issues, and they're more likely to make referrals. But the good news, I'm eternally optimistic, is that this is changing. So I think that there's less stigma associated with suicide in religious communities. People are looking more at not demonizing mental illness, but really thinking more about it in terms of a challenge, in terms of mental health or health status, and looking less at the issue of whether or not suicide is an unpardonable sin in some communities, but looking more at it as a mental health challenge. There's much more focus on being compassionate towards people who have mental health challenges as well. Mental illness is also now beginning to be seen like other diseases and not a reason for shame. In my own church, we talk a lot about, because I have asthma, it's pretty well known in my congregation, so I often make analogies to my asthma and to, for example, the need for taking medication. If I don't take my medication, I'm more at risk for having an asthma attack, and if you don't take your medication, then you're more at risk for having an episode. We also see, really importantly, that more and more clergy persons are seeing themselves as a member of a team and that they have an important role to play. They're not to be the substitute for a mental health professional, but they're an important resource for mental health professionals. There's a really good book out called Cultivating Wholeness, and it talks about the fact that faith leaders are designed to cultivate gardens, and that the garden or the soil is basically the holistic approach to persons' physical and mental and spiritual well-being. And that there's a concept called mattering. I don't know if you've heard about this, but mattering is basically not just feeling accepted, but feeling really important. What you think, how you live, how you behave, what you're going through is really important in that community. And there's lots of research that suggests that when people feel that they matter, even in the middle of a mental health crisis, that they have better outcomes. One of the ways that we can do that is connecting people. I think there's often a lot of concerns about doing interventions in faith communities because of the stigma associated with suicide. But the other really strength that faith communities have is that they're really good at connecting people. And we know that connectedness on multiple levels is really important. I work more with youth. And one of the things I love about working in faith communities is that even if the youth is not a member of that community, that most faith traditions or faith communities really love working with youth and will work with youth and incorporate them into programs that they have, even if the family or the child, his or herself, are not members of that congregation. It's a wonderful opportunity to have education, narratives of hope, worship experiences, and advocacy, and I'll go into these in a few details. So, as I said earlier, you can foster a sense of connectedness and mattering both in and outside the four walls of the edifice or the institution. These are just some examples. Easter egg hunts, for those of you who are Christians, we recently had Easter. That bottom picture is actually my church, where we have a family day every year, and we just spend with our normal service, and we actually have games being played, and that's my daughter playing some kind of card game in the bottom. So shout out to my daughter. We have lots and lots of educational opportunities. So in my church, we do series and Bible studies, and we just finished a series on scandals. We've also done series on queer theology. We've done series on mental health issues. We do lots of sermons. One of the biggest ways that you can make changes is to normalize the conversation. So we have inserts in our bulletin about suicide hotline. We have a community table, and we have mental health information about that. We really focus a lot not just on suicide, but on help seeking. Because I think that for all of the good ideas we're going to talk about today, if we don't encourage people to normalize help seeking, it's not going to matter. We could have a clinic in every place. We could put all these great things in schools. If we don't change people's norms about that it's okay to seek help. So part of what we do in our faith communities, we normalize the conversation about help seeking. In July, there's a Minority Mental Health Month, and every year we have telling our stories. I remember people earlier talked about telling their stories. And one of the most powerful things that we do all year is those storytellings, where people get up and talk about family members or themselves, their challenges with mental health. It's very hopeful. One of the most powerful ones was my youngest daughter did hers about 6 or 7 years ago and talked about her struggling with bullying in her school and how mental health resources, particularly she said CBT, really helped her. And she's doing really well now. So those stories have a really big impact. We also know that in faith traditions, there's often narratives of hope. Historically, this is an example of the civil rights movement. Again, there's a lot of faith communities that will have grandparenting programs where they'll have older people adopt children who are younger, and they may or may not have grandparenting in their lives, and they just engage in activities. Worship, again, I love doing things in faith communities because you have a captive audience, and sermons are designed to be persuasive one time. So this is a challenge for researchers, though. Oftentimes, we've written several grants that have not been funded, and one of the comments has been, we're not heavily dosing our messages enough, and it's a realization that science and the faith community has different ways of messaging and coping and presenting and communicating information. So a sermon is designed to be impactful once. And so these are things that can help and really helpful. I already talked about telling our stories, and we don't just do it around suicide. We do it around people. We have members of our church who have children on the autism spectrum, bipolar disorder, or PTSD. We have members who talk about taking their medication. They name the medication. I love Lexapro, why they do and don't like it. So that's really important. I've already talked about the community tables. Our website has information, our Facebook page. One of the most powerful things you can do is use social media. So this conference today is on my personal Facebook page, but it's also on my church's Facebook page. It's also on my denomination's website. So every time I can do that, I'll be tweeting throughout the conference. And so you can reach a lot of people. My church is a small church, but we have about 400 or 500 hits a month. So even with 60 people, it's amazing. And those people go on to share more information, so that's really important. Treating prevention as a social justice issue is actually a different lens to use, but it's also one that people in our community at least can easily resonate with. And so it also helps to reduce the stigma to talk about it as a social justice issue, that just like everyone should have access to health care, everyone should have access to mental health care. Let's see, there's also people in the, we also call it policy in the pulpit. It's kind of a really good important platform that you can have to help to change policy and to encourage members of your community to talk to their congresspersons, for example, when legislation is coming up. So all of those things, both locally and nationally. So the take-home message is that faith communities are an untapped resource. It really does take a village. Caring for persons with mental illnesses and their challenges really involves partnerships. I think faith communities and their leaders are a really important part of that village, and I think that they inherently have many protective factors that we can access and rely on. The other thing is that as a clinician, I'm only going to see someone once or twice a week. A faith person, a faith leader is going to see that person many more hours a week, has access to them, and the bottom line is we make house calls. So I think it's an important resource that we need to take advantage of, and to realize that with the team approach that we can all work together to make people whole. These are just resources. People have already talked about these. And Action Alliance has great resources and tools. So does the Suicide Prevention Resource Center. If you need to get statistics that can be localized to your community, the CDC is also a good resource. And so thank you.
Great. And now we have Francis Gonzalez, who's Senior Director of Marketing and Communications for the National Suicide Prevention Lifeline and Vibrant Emotional Health.
Hi. Thank you for taking the time to listen to me talk about community solutions. So how do I even do this? Okay. Perfect. So the National Suicide Prevention Lifeline, we've heard it mentioned before. I hope that you might be familiar with our number, 1-800-273-8255. And the Lifeline's mission is to reach and serve all persons who could be at risk of suicide in the U.S. through a national network of local crisis centers. So we are SAMHSA funded. We are administered by Vibrant Emotional Health, which is my parent nonprofit. And we're made up of over 160 crisis centers, local crisis centers in 49 states. And we also support the National Disaster Distress Helpline and provide support for the Veterans Crisis Line as well. And the reason why I'm mentioning the network of over 160 centers is because it puts us in a unique position. So we are a national line. That we encourage people to share that national number, but when you call the Lifeline, you are routed to a local crisis center. And when you do that, that provides opportunities not only on the national level to share messages of hope and recovery, but also on the local community level. So working with organizations, working with local crisis centers in order to integrate suicide prevention and the Lifeline into their local communities. So how does the public feel about suicide prevention? So we have found that 94% of people believe suicide is preventable. 94% of people would do something if someone close to them had suicidal ideas. I have a lot of questions for like the other 6%. So 64% of people would encourage friends and loved ones to seek mental health help. I do want to note that only 38% of people would share hotline information or another resource in those moments of crisis, which is extremely notable for us. And 78% are interested in learning more how they could help people. So 94% of people believe that they would do something, but almost 50% of Americans identified barriers that stopped them from trying to help someone who was at risk in those moments. And those fears were based on why they didn't do it was based on fear that they would say or do something that was wrong, and that would make it worse instead of better. And also a very fundamental lack of education, not knowing how to find help for that person in crisis. So for Lifeline Communications in particular, not only do we work to promote the Lifeline phone number, but we also work to come up with resources and messaging to address the needs of the general public like this. And so one of our key messages is focusing on stories of hope and recovery. So healing, hope, and help are happening. This used to be the suicide is preventable message, but we felt that instead of just saying saying suicide is preventable, what we needed to do was illustrate those stories of hope and recovery that are actually happening every single day in different communities around the nation. So we want to share those stories of hope and recovery and focus on the people in crisis now, as well as those who've survived crisis, illustrating those things that help them get through those difficult moments and the people who help them get through those difficult moments. And so that is supported by our second message. Everyone can take action to prevent suicide. How we frame this message is one of personal empowerment and community connection. So we want to remove suicide prevention from the professional mental health realm only and make it a universal message, something that can be applied across communities, and not only across communities, but through interpersonal interactions and connections. And so Be the One Too was born. So Be the One Too was started in about 2015. And these are 5 action steps that any person can take to help somebody in their life that might be in crisis. They are evidence-informed, and they are intentionally written to be very accessible to everybody. So with the notion that you may be in a situation where you don't know what to do, so you're having a conversation with your friend, you realize this person might be going through something, but now you think to yourself, I don't know what to do now. And so these 5 steps serve as a blueprint, or as we like to say, suicidal crisis CPR, that can sort of walk you through that interaction from beginning to end. So asking someone if they're suicidal, keeping them safe refers to asking them how they would hurt themselves and removing that means from them. Be There talks about how to listen without judgment and effectively. Help Them Connect talks about how to connect that person to other supports and resources, whether that is faith, a church, counseling system, the Lifeline. and also following up. So checking up on that person in the days and weeks after a suicidal crisis. We launched this in 2015, and we have over 50 partners who've participated in this at some point or another. And this started as a digital campaign, but as we built it out, we realized that what we wanted to do was to offer a national framework, but also opportunities for adaptation and customization on the community and local level. So we designed it to have a lot of different ways of participation, whether that's just sharing the steps on social media, creating your own graphic kit if you have the resources to do that, sending a postcard or sharing a postcard with us, talking about the time somebody has helped you through a crisis, participating in a Twitter chat, hanging up posters, and donating to your local crisis center. Now, these are only a couple of the ways that people have helped to promote the Be the One, Two steps. They're also integrated them into systems that they already have. For instance, the U.S. Navy has integrated the Be the One, Two steps into existing toolkits that they were already creating, and these are now integrated as a section of those kits. Metro North Railroad created posters that illustrated the different steps and encouraged people to check out the website that they hung on their trains and also in their stations. And also the Office of Mental Health in New York City utilized Be the One, Two as a potential grant program for their local community organizations, asking them to take Be the One, Two and find ways to customize that for the communities that they were serving. So this is just an example of a customization that we have on our website, people creating their own kits and organizations creating their own kits that more accurately reflect the communities that they're trying to serve. How does this work in media? We also encourage our local crisis centers and our partners to integrate the message of Be the One, Two, which is that everyone can do something to prevent suicide, as well as those individual steps in their talking points when they're working with media, with local community partners, when they're addressing local incidents in their own towns. So these are just two examples on more of a national scale of how we integrated that. So the first one on the left is in a recent reprinting of 13 Reasons Why. We worked with them to include the Lifeline number, but also Be the One, Two. We also worked with CNN in June 2018. I'm sure all of you are familiar with Anthony Bourdain dying by suicide and Kate Spade dying by suicide. And CNN actually approached us and said, hey, we see that you have these steps that are available. Can we put them on our site during our coverage? And the answer, of course, was yes, please do. Okay, in addition to that, talking more about digital communities more specifically. The same idea of a framework, which is to provide standards across the country, but then allow for customization and implementation on a community level. So the Lifeline has worked with social media platforms for over 10 years to develop safety processes for suicidal individuals. You can see some of those logos there. We also have a Facebook page with over 300,000 followers and extremely active moderation. And we also realized we were receiving a lot of the same questions over and over from the public about social media posts that they were encountering on their own forums. And so we came up with our social media toolkit. We released this in September 2018, and what this was is a turnkey set of guidelines for moderators, community moderators, social media platforms, and also users on the individual level. So the kit works to identify and help promote engagement with people in crisis online and addresses common recurring questions. And it, once again, is also designed for people who are unfamiliar with the mental health space. It also is designed to be educational. The idea is that we want you to take this kit, educate yourself about how to recognize people who are in crisis online, but also to customize your engagement with that individual in order to match the tone or the needs of your specific group, because we believe that you, above all else, know what your community particularly needs, or the users of your community needs, and we provide the insight and the guidance as to what those resources should look like and how they should be implemented. For instance, we do provide canned messaging, but we also provide guidance on why the canned messaging is how it is. So considering a post about suicide to be serious and genuine, developing a system of monitoring and responding when someone's in crisis, crafting responses that are sensitive to the situation, but realistic as to your ability to handle those situations, and educating people about imminent risk in those times when you may need to actually reach out to emergency services. We found that this actually has a much broader use than it was originally intended for forum moderators, blog posts, things like that. We found that it is actually useful for all communities with some form of digital presence. So we've provided it to influencers, content creators, and storytellers who are actively sharing stories about mental health or who are interested in sharing stories about mental health. We've provided it to the SAMHSA Office of Communications. We've also shared it with journalists and media organizations who are thinking about writing stories of suicide prevention, but are worried about doing so because they're worried about the kinds of comments they're going to get when they post that story online. And we can say to them, hey, yeah, you can write these stories, you can prepare for what might come in advance. We also provide it to public figures with large social media followings, as I mentioned earlier. So there are postcards in the back about Be the One To. Please take them because I don't want to bring them home. You can find more information about the Lifeline at suicidepreventionlifeline.org and our parent org at vibrant.org. And of course, there's my information there if you'd like to talk more about these solutions.
Hi, everybody. This was a fantastic panel. Thank you so much for your comments. I'd like to encourage the group now to take some of the information that you learned from this panel on the community context and apply it to an exercise that we'll be doing at your seats, at your table. So first, can I ask our facilitators that are sitting at each table to raise their hand? Okay, so this is your facilitator, and we'd like to pick up on some of the themes that were addressed in the conversations at the table. So your facilitators will give you guidance about the exercise that's coming up, and we also encourage you to ask our panelists questions over lunch, which will happen after this exercise, okay? Great, thank you. Thank you all.